When we think about the diagnostic hierarchy in psychiatry, many of these patients either pre-existing may have a diagnosis of depression or anxiety or PTSD or trauma-related disorders. What tends to happen is if we keep these separate, what I mean by that is, for example, they've got a diagnosis of depression, anxiety, and they've got a diagnosis of, say, POTS, or they've got chronic fatigue syndrome. These two are actually interlinked in many ways. So what we've got to do is to understand the bidirectional relationship of this. For example, a patient with pre-existing depression in the context of, say, an EBV infection, glandular fever, or post-COVID may actually develop a depressive syndrome that might be different from their pre-existing depressive syndrome. And that's what we've got to identify. So what we've got to do is not keep these separate. What I mean by that is to move away from that brain-body or mind-body dichotomy, but rather incorporate all of this into the formulation.